Good evening, friends. Today we are going to discuss interpretation of thyroid function test and various problems or pitfalls associated with its interpretation. Now, everybody thinks that interpretation of thyroid function test is quite easy, but as we go through this lecture, we will find out that it is one of the most interesting, complex, and intriguing problem for which patients are being referred to us for various types of thyroid function tests. Now, if you have to understand thyroid function test, you have to understand basically the concept of hypothalamo-pituitary thyroid axis. From hypothalamus, TRH is secreted, which act on pituitary gland. From pituitary, TSH is secreted, which in turn act on thyroid gland, resulting in secretion of T4 and T3 from thyroid, which goes back to pituitary and hypothalamus and controls the secretion of TSH and TRH. Now, as you see in this slide, there are also numbers like D1, D2, and there is a number which is missing here is D3. Now, this stands for deiodinase enzyme. Now, majority of thyroid hormone which is secreted from thyroid gland is T4. Only 20% of the secreted is T3. Now, the remaining is converted into periphery at various organs. Now, this conversion takes place through an enzyme which is known as deiodinase enzyme. There are three types: D1, D2, D3. Now, as you have seen in thyroid, both D1 and D2 are present. In pituitary and hypothalamus, T2 are present, which means T4 is converted to T3 by local D2 deiodinase, and it is actually T3, which is a metabolically active hormone required for carrying out various functions of thyroid hormones. Similarly, as you see in thyroid gland, skeletal muscle, cardiac muscle, D2 is expressed. In contrast, in liver, kidney, and thyroid, D1 is expressed. So, therefore, different organs have different deiodinase enzymes. Now, D3 is responsible for converting T4 into an inactive form, which is reverse T3. Now, why it is important to know? Because when we will be seeing various medical conditions or various thyroid function tests, sometimes these even deiodinase enzymes are responsible for causing alteration in thyroid levels. After secretion from thyroid gland, T4 and T3 are bound to plasma protein. There are three types of proteins to which it is bound. 80% of it is bound to globulin, which is known as thyroid binding globulin. Around 10% is bind to transthyretin and 10% to albumin. Again, it is important because if in our plasma, the level of these proteins are going to be altered, our thyroid function test is going to be changed. Now, these plasma proteins carries T3 and T4 to various tissues, and in the tissues through this transporter, which is mentioned here as MCT8, monocarboxylate 8 transporter, the thyroid hormone goes inside the cell. Now, once inside the cell, it will bind to the nucleus and will cause various physiological action of thyroid hormone. So, this is in brief and very simplistic form how thyroid hormone is secreted from thyroid gland, carried in the plasma to various tissues, and then entering into the nucleus and carrying out various thyroid function tests. Now, it is not uncommon because now the facility is available in the smallest town. Patient get that T3, T4, TSH done even without prescription. Now, routinely, TSH is used as a screening test. Now, if TSH is normal, we believe that patient is normal. If TSH is low or high, then we measure T4. And depending on the level of T4, patient can have hypo or hyperthyroidism. But this stands true for primary hypo or hyperthyroidism, which means when problem is primarily at the level of thyroid gland. But when the problem is at the level of pituitary or hypothalamus, this algorithm does not hold true, because in that case, for hypothyroidism, T3 is low and TSH is also low, while the reverse happens for hyperthyroidism. So this is a simplistic view to make you understand that how do we diagnose routine majority of cases as hypo or hyper or subclinical hypothyroidism and subclinical hyperthyroidism. Now, as I have told you, there are many pitfalls in diagnosis of thyroid function test. And as you see in this picture, number of names are given when thyroid function is discordant with clinical picture of the patient, or TFT within are discordant with each other, which means T3 is moving in one direction, T4 moving in other direction, and number of names are given in the literature, which include anomalous TFT, discordant TFT, funny TFT, and so on. So therefore, friends, when you see T3, T4, TSH, remember there is a log inverse, log linear relationship maintained between T3 and T4 and TSH because of inhibition process, which I have described to you. So a normal individual will have a normal T3, T4, and TSH. Now let's see the first scenario where T3, T4 is low and TSH is high. Now this is known as classical hypothyroidism. Apart from that, as you see in this cartoon, and this cartoon will show you at least 30 different conditions which are responsible for different permutation and combination. Patient can have elevated FT3, F2 and depressed TSH, which is classical for thyrotoxicosis. And then there are different other permutation and combination. I will not read this slide in detail because this itself will take around 10 to 15 minutes. But as you see and as you count the number of bullets, as I have told you, different permutation and combination, at least 30 are possible. So to make the things easy and to make you understand, I have made some cases and we are going to discuss through these cases. So let's discuss case 1. 47-year-old women. Patient comes with increasing tiredness and fatigue. Weight is stable, no constipation. Patient has received radioiodine therapy for hyperthyroidism in 2016. And patient is currently receiving levothyroxine 275 micrograms per day. Apart from that, because of patient tiredness, fatigue, sleepiness, patient has also been prescribed gabapentin and citalopram. Now, when this patient comes to us on clinical examination, thyroid is not palpable, patient is appearing myxedematous, and when T3, T4, TSH is done, TSH is more than 100, and as you see, FT3 and FT4 are below normal range, which means despite receiving 275 micrograms of thyroxine, patient is still hypothyroid. So the question for all of you who are attending, I know there are no options for the poll, but then what is the likely reason that despite receiving 275 micrograms or supraphysiological doses of levothyroxine, still patient is hypothyroid? So there are 5 choices here. As you can read: elevated T4, T3 binding capacity, enhanced metabolism, increased conversion of T4 to T3, malabsorption, and non-concordance or non-compliance with thyroxine therapy. Anyone will like to comment?
You can put your comments in the chat box also.
So if we see further, this patient, the first thing which comes to the mind is negative, is celiac disease, which is quite common in our northern part of the country. But in this patient, IgA TTG is negative, which means celiac disease, which is one of the most common cause for malabsorption is negative. Now, whenever we see such type of patients, these are different reasons for reducing efficacy of levothyroxine, which are enumerated here. We should consider SA interference, which is also quite common, responsible for falsely elevation of TSH, but in that case, T3, T4 should come as normal. The next is we should consider levothyroxine malabsorption. I have enumerated you celiac disease, but there might be other GI disorder. Apart from that, dietary factors like coffee, tea, or milk consuming immediately after taking levothyroxine. Now, it is quite common we prescribe patient to take levothyroxine empty stomach. But we fail to emphasize empty stomach means after taking tablet, patient should not consume anything, including tea, coffee, for at least 40 minutes to 1 hour after taking the tablet. Now, what is normally happening? Patient consumes tablet and within next 5 to 10 minutes, they go for the tea, coffee, or other drinks, which is responsible for decreased absorption. Then, as you see, there are number of drugs which are over the counter available in our country, and patient consumes them regularly. And one of them is proton pump inhibitor or drugs for acidity. Again, large number of patients are taking them empty stomach after getting up in the morning. They are also responsible for decreasing the absorption of levothyroxine. Similarly, as you see, iron tablets, calcium tablets, and so many other drugs. The next important consideration is increased metabolism or increased excretion or increased binding capacity, because of which the free thyroid hormone is not normal. Now, increased binding capacity is seen specifically in women if they are on estrogen therapy. Apart from that, increased metabolism is seen. Suppose an epilepsy patient is on phenytoin, phenobarbital, carbazepine, all these anti-epileptic drugs increases the metabolism of levothyroxine. Similarly, patients of tuberculosis of any type, when they are on rifampicin also increases the metabolism of levothyroxine. Again, causes increased demand. Imatinib is a drug which is used for CML, chronic myeloid leukemia. Again, causes increased demand. And then, apart from that, compliance is always an issue. So whenever we see such type of patient, one way to diagnose is to do a supervised thyroxine absorption test. How do we do? Pre-test, we exclude the confounding factors like dietary factors, take thorough drug history, rule out celiac disease by doing IgA TTG, and then ensure that patient is not suffering from cardiac disease. Then direct supervision, either as a tablet or if liquid, whatever is available. In our country, it is tablet, and we round it to the nearest 50 microgram. So whatever is a 7-day dose, we give it directly supervised. And after that, blood samples are drawn. Now we continue this weekly supervised for next 5 weeks and continue to collect the samples of thyroid hormone. Now then, after 6 weeks, and why 6 weeks time? Because T4 has a half-life of 7 days. It takes minimum 5 half-life to maintain a plasma level. Therefore, we wait for 6 weeks. And then, if TSH is normalized, it means non-compliance, non-adherence, patient is not coming up with true history. If there is an inadequate rise, then probably it is malabsorption, and we have to work carefully, try to find out various GI causes. Now let's discuss the second case. A 77-year-old female suffering from hypertension, receiving amlodipine 10 milligram a day. Patient recently had a fall, developed fracture of femur on the left side. Post-operatively, patient developed atrial fibrillation, and then heparin was also started. Patient is euthyroid, no goiter, AF, heart rate of 110 beats per minute, examination, rest of the examination is normal. Patient thyroid function test was ordered in the hospital and TSH is found to be 3.2, which is in the normal range. Free T4 is found to be 35 with normal range of 20, which means FT4 is elevated and TPO is negative. So the question for the house is why this TFT is seen? What is the reason for this TFT or interpretation? Again, you can have your poll or somebody can say, and I have again given the 5 choices: drug effect, non-thyroidal illness, radio contrast associated thyrotoxicosis, subclinical hyperthyroidism, TSH secreting pituitary adenoma. This is your TFT. So moving from this, remember, as I have told you, drugs are very important cause for altering thyroid function tests. Now, heparin is a drug which is commonly used in hospital whenever patient develop various types of medical illness. Whether you are using regular heparin or ultra fractionated heparin, heparin, remember, causes activation of lipoprotein lipase. By doing so, it causes release of free fatty acid from adipose tissue. Now, when there is a rise in free fatty acid, it will compete with the thyroid hormone for binding to thyroid hormone globulin, resulting in increased level of free thyroid hormone. Therefore, in such cases, when you will case, it was found to be normal. So we received this call for patient admitted in ICU, and when we have seen the entire history, we found that the patient was receiving heparin. So therefore, in any such case, before making a diagnosis of hyperthyroidism, a regular heparin should be stopped, which is you are giving for intravenously for at least 6 hours, or subcutaneous heparin has to be stopped at least for 24 hours before taking thyroid sample, or preferably if in ICU you are going to start heparin therapy and you are planning to measure T3, T4, TSH, then withdraw sample before first injection of heparin. In that way, you will avoid this anonymous T3, T4, TSH. Now, there are various medications from this case, which I will like to emphasize. Whenever you are called or you have to see your patient for altered thyroid function test, remember, large number of drugs are going to change your thyroid hormone levels. There are drugs which can increase or decrease the TSH synthesis. Now, these include corticosteroids, one of the very commonly used drugs, dopamine, octreotide. Now, there are drugs which can decrease the thyroid hormone synthesis, which include iodine, lithium, methimazole, propylthiouracil. There are drugs which can decrease the conversion of T4 to T3. So therefore, T4 and T3 is also not matching with each other in a given TFT. We will come to that case. Commonly used drug is amiodarone in cardiology practice, corticosteroid, propranolol. There are drugs which can decrease the TBG level. Remember, 80% is bound to thyroid binding globulin. So if TBG levels are decreased, total T3, T4 will be reduced. Various drugs include androgens, corticosteroid, niacin. There are drugs which can increase TBG levels like estrogen, heroin, tamoxifen, and so on. Various anti-cancer drugs like 5-fluorouracil. There are drugs which can increase the metabolism. Again, I have already enumerated them, like anti-epileptic drug, rifampicin, sertraline, which is an antidepressant. Drugs which can displace thyroid from their binding protein. We have just shown you an example of heparin. Apart from that, aspirin in high dosage, carbazepine, Lasix, another common drug used in ICU, decreased absorption because of antacids, iron, calcium, soya products, and lastly, thyroiditis, inflammation, viral inflammation of thyroid gland, which can cause pictures and which can cause interference in thyroid function test. So there is a list is long. I know it is difficult to remember, but with experience, you can learn it or you can keep it on your table. Moving from that to our third case, 72-year-old male suffering from chronic obstructive pulmonary disease, congestive heart failure, admitted to ICU with urosepsis due to BPH. Patient was in shock, intubated, thyroid function test was ordered, and this is a thyroid function test. TSH 0.35, FT4 9.5, total T3 0.3. So all the three are reduced. What is your interpretation? Now, this is a classical example of non-thyroidal illness, NTI. Previously, it was known as sick euthyroid syndrome. Remember, if your patient is sick, if he is not suffering from thyroid disease, clinically there are no features suggestive of hypothyroidism. Try to avoid ordering T3, T4, TSH in such sick patients. Otherwise, you will be confused. I have shown you an example where T3, T4, TSH are all reduced. And if by mistake you will start thyroxin replacement in such patient, that will be catastrophic because giving thyroid hormone replacement in such cases is found to be associated with increased morbidity and mortality. There are many reasons. We will not go into the reasons of pathophysiological details, but remember this type of thyroid function test is quite common in severely ill patients. Apart from that, severely ill patients are on steroid therapy, they have a cytokine milieu. All these things are responsible for causing such changes in thyroid function test. Now, as you see very clearly, depending on severity of illness, initially T3 is reduced. But as the severity of illness progresses, even T4 started reducing, and in markedly sick patient, all the three T3, T4, TSH are reduced. Remember, if you are seeing a patient with low FT4, it is associated with more than 85% mortality. One important thing is to rule out central hypothyroidism. Therefore, measure cortisol level in such patients. If this is a central hypothyroidism, cortisol will also be low. Otherwise, in critically sick patient, cortisol levels are high. Now, moving from non-thyroidal illness to our case 4. This is a 40-year-old lady presented with non-specific body aches, no goiter, all clinical feature investigations are normal. TPO antibody is negative. Patient T3 is in the normal range. T4 is in the normal range. TSH is 6.3, which is slightly elevated. The doctor concerned has started the patient on levothyroxine 50 microgram, seeing her TSH to be high, making diagnosis of subclinical hypothyroidism. After 3 months of levothyroxine, thyroid function test is repeated. Again, it is found to be same. TSH is 6.2. 3 months back, it was 6.3, which means no difference. Now, always remember, patients are, in our country at least, are even consuming over-the-counter medications, which include biotin. Biotin is a normal supplement taken for hair falls, brittle nails, in multivitamins. These are going to interfere with your thyroid hormone assay, and we often forget to take such type of history. Now, when you stop such type of offending drugs, T3, T4, TSH become normal without giving any drug to this patient. So this is an example where thyroid function assay interference because of biotin supplement is responsible for a slight rise in TSH. Moving to case 5, a 75-year-old man suffered from myocardial infarction, and then patient also suffered from non-sustained ventricular tachycardia. Patient was on drugs. I will not read the drugs for cardiac reasons, all the drugs. After 1 month, patient was again admitted with non-sustained VT. Now, a thyroid function test was done, which shows T4 which is elevated 13.5, T3 which is 60, TSH which is 5.2. A call has been sent to us. Now the case is in front of you. What is your interpretation? Now if you see in this case, the offending agent is amiodarone. Now amiodarone is a drug which is structurally related to thyroid hormone. It contains 39% iodine by weight, which means a typical dose of amiodarone, which is 200 milligrams per day, causes more than 40-fold increase in your plasma and urinary iodine level. Also remember, amiodarone is stored in adipose tissue. So therefore, high iodine level persists in the body for more than 6 months. And amiodarone has number of effect on thyroid gland. It causes transient suppression of thyroid gland. Hypothyroidism is seen in patients who are susceptible to high effect of iodine, which is Wolff-Chaikoff effect, and thyrotoxicosis is seen in a given patient, which is known as Jod-Bashidose effect. Also, it inhibits D2 deiodinase enzyme, which I have shown you in the first slide. So various patterns of thyroid function test are seen in patients who are on background amiodarone therapy, like increased T4 seen in our patient, decreased or normal T3, increased reverse T3, a transient increase in TSH up to 20. Patient does not need any therapy, only we need either to stop TSH, because as you stop, the functions are going to be normalized. There are two types of thyrotoxicosis seen in amiodarone patient, type 1 and type 2. For type 1, we need neomarcosol therapy. For type 2, we need steroid therapy. Now, last case, before I will stop, we'll have some question and answer. 69-year-old lady, and patient has a serial thyroid function test. Again, as you see, TSH is slightly elevated, FT4 is elevated, and FT3 is elevated with positive TPO antibody. So what is your diagnosis here? T3 is elevated, T4 is elevated, TSH is elevated, and patient is also having atrial fibrillation. So in such case, the two important differential diagnoses is TSH secreting pituitary tumor and resistance to thyroid hormone. How to differentiate? This slide will summarize that how to differentiate between these two, where all the three are elevated. Now in TSH secreting tumor, pituitary MRI will be abnormal and sex hormone binding globulin is elevated. Now there are also elevated alpha subunit, but measurement of this is not freely available in our country. In contrast, in patients who are suffering from resistance to thyroid hormone, they have normal SHPG, normal pituitary gland, and when you screen their first degree relatives, although they are also asymptomatic, you will find similar degree of thyroid function test even in first degree relatives of such patients. So therefore, friends, practicing and thinking about thyroid function test requires some careful interpretation, understanding that how TFT is linked with each other. And I will like to stop here by showing my last slide. Fresh thinking rather than predetermined or predictable thinking is required, because practicing medicine is an art of interpretation of science and its application to human health, behavior, and disease. Thank you very much.
So if any of the audience wants any question, they can unmute themselves and ask directly to Dr. Rajput.
Sir, there are certain conditions, especially in the pediatric age group and in pregnancy. How do we need to treat the subclinical hypothyroidism or not?
Subclinical hypothyroidism during pregnancy.
During pregnancy and in kids, sir, since they are in the growing phase.
See, in pregnancy, you need to treat subclinical hypothyroidism, because definitely we do not want pregnant mother to carry a baby, which can affect even the brain development in such a kid. Now, there are well-led guidelines. Indian Thyroid Society, I was president of Indian Thyroid Society. We have come up with a document which clearly state how you should treat or how you should diagnose pregnant ladies and how you should treat such ladies. So there is no confusion. Subclinical hypothyroidism needs to be treated during pregnancy, and trimester specific thyroid function test needs to be maintained. Now, as far as kids are concerned, again, as I've kids is an important age, and again, subclinical hypothyroidism. First of all, you have to document actually you are diagnosing correctly subclinical hypothyroidism. And if the diagnosis is correct, again, kids needs to be treated with levothyroxine. Dosage are different. They are not same as those in the adults. It is based on body weight, and the body weight dosage are different in kids.
Sir, there is one patient, she's pregnant, second trimester, and her TSH is raised, her T3 is raised, and her T4 are raised, and she's on thyroxin 75.
मैडम आपने T3 T4 नापा है ना? मैंने पहली स्लाइड बताई थी कि प्रेगनेंसी की थायराइड हार्मोन is bind to thyroid binding globulin. In pregnancy, globulin levels increases. Therefore, T4 and T3 levels are elevated, and they are elevated up to 1.5 times the non-pregnant range. So, यदि आप T3 T4 यूज कर रहे हो तो उसकी जो अपर नॉर्मल लिमिट है उसको 1.5 टाइम से मल्टीप्लाई करो और फिर आप देखोगे कि वो T3 T4 नॉर्मल रेंज में ही है. और else you should measure FT3 and FT4 which are not affected by your thyroid binding globulin which are increased during pregnancy. तो वो नॉर्मल मिलेंगे आपको. इसलिए इस पेशेंट में TSH नॉर्मल है और T3 T4 थोड़ा सा बढ़ा हुआ है.
हेलो डॉक्टर राजपूत, नमस्कार सर, कैसे हो? हेलो
हाँ डॉक्टर खन्ना,
हेलो, हाँ कैसे हो
go ahead with your
डॉक्टर?
question.
हाउ आर यू? हेलो डॉक्टर राजपूत, कैन यू थ्रो सम लाइट ऑन द यूज ऑफ लाइनोम
Light on.
T3 लाइनोम.
T3 is a different preparation, not to be used routinely, and it's a separate lecture actually how to use T3 in a patient who is already on T4, because
Yes.
then the dosage of T4 also needs to be reduced to somehow. T3 alone is not to be used in any hypothyroid patient. It has to be used in conjunction with T4 therapy, that too in select patients. Isolated use of T3 is only there when we see a patient of thyroid cancer, papillary thyroid cancer or follicular thyroid cancer, and we are preparing them for radioiodine therapy. Isolated use of levothyroxine is used there only. Otherwise, T3 when used in combination with T4, we will discuss in detail how to calculate the dose of levo LT3 to be used in such type of patients. So in select 10% of such patients, there is a role routinely we should avoid. In elderly patient, kids, we should definitely avoid T3 because it is in our body, we have a regulated system where T4 is converted to T3 in a regulated environment. If you give T3 directly from outside in elderly patient who have underlying cardiac disease, it may precipitate angina, it may precipitate heart failure, it may precipitate arrhythmias. So therefore, worldwide, T3 is not a preferred form of therapy for treatment of subclinical or clinical hypothyroidism. It is only in select cases where we use it in combination with levothyroxine, that is T4. Only in myxedema cases, only in patient who are post-operative cancer patient waiting for their radioiodine therapy, we use T3 alone for some reasons.
Thank you, Doctor. Thank you.
There is a question from Dr. Deepak Sharma. In which case we have to go for total, and in which other case we have to go for assaying free form of T3, T4?
Routinely, we should only measure total T3, T4, TSH. Pregnancy is one condition where free T3, free T4, TSH can be measured. Or when you see an anomalous or discordant thyroid function test and you are suspecting that this change in T3, T4 is because of alteration in thyroid binding globulin or albumin, then you should go for free T3, free T4 measurement. Also, if your patient is suffering from cirrhosis, which is responsible for decreased albumin level, if your patient is suffering from nephrotic syndrome, passing lots of albumin in the urine, have hypoalbuminemia or hypoalbuminemia per se. In all such cases, we can go for free T3, free T4. Otherwise, routinely in majority of cases, it is only total T3, T4, TSH, which will suffice the purpose.
Thank you, sir. Any other question from anybody else?
Dr. Pawan, there is one more question from Dr. Deepak. Is there any machine-related variation in results?
मशीन रिलेटेड वेरिएशन नहीं होती सर, ऐसे रिलेटेड वेरिएशन होती है। मशीनें तो आजकल जो स्टैंडर्ड आती हैं, अच्छी मशीनें किसी भी अच्छी कंपनी की सभी बढ़िया है। कौन सा मेथड यूज हो रहा है उस मशीन में वो डिपेंड करता है। आजकल लेटेस्ट इलेक्ट्रोकेमिल्यूमिनेसेंस मेथड है, यदि उसको यूज कर रहे हो तो ऑलमोस्ट इंटरफेरेंसेस काफी हद तक सॉल्व हो जाती है। बाकी अगेन बड़ा कॉम्प्लेक्स टॉपिक है, और जब आप कोई मशीन खरीदो तो जिस मशीन वाले से आप खरीद रहे हो उससे पूरा मशीन का मेथड और जो इंटरफेरेंसेस है उस मशीन और उस मशीन में जो रीजेंट इस्तेमाल हो रहा है वो हमें पूछ के रखनी चाहिए, वो हमें बहुत मदद करती है।
And what about assaying this thyroid hormones with the fluorescent immunoassay? How correct they are?
कौन सा ऐसे?
Fluorescent immunoassay.
फ्लोरोसेंट इम्यूनोएस्से तो कोई यूज करते ही नहीं ना, अब तो इलेक्ट्रोकेमिल्यूमिनेसेंस यूज करते हैं ना, या नॉर्मल केमिल्यूमिनेसेंस यूज करते हैं।
So fluorescent immunoassay technique is not good.
तो इसलिए अब तो नए एसेज, नई मशीनें जो आ चुकी हैं, थिंग्स आर टोटली डिफरेंट। पुराने जमाने में जब ऐसे होते थे, अब तो 4th जनरेशन के एसेज आ चुके हैं। तो आजकल जो भी नई मशीन लगती है वो तो लेटेस्ट, सो लार्जली इन इंटरफेरेंसेस से ये टेक केयर अपने आप हो जाती है।
There is a question from Dr. Neelam Bist. What are the guidelines for treating subclinical hypothyroidism in patients undergoing assisted reproductive measures?
It is same as in the pregnant women. There is no difference. We have to maintain TFT within normal range. So again, this guidelines are very big, but one portion of reproductive guidelines is assisted reproduction technologies, and the levels are almost similar. Trimester specific thyroid function test has to be maintained.
There is a question from Dr. Itisha. Low T3, low T4 and normal TSH. How to interpret it?
मैंने बताया था केस क्रिटिकली सिक पेशेंट।
And target level in pregnant with hypothyroidism.
I think target levels depending on trimester, upper limit is different, lower limit is different. For upper limit, for first trimester we take 2.5 to 3, सेकेंड और थर्ड ट्राइमेस्टर में 4 से नीचे नॉर्मल है। इसलिए मैंने आपको बोला इंडियन थायराइड सोसाइटी की बड़ी क्लियर गाइडलाइंस है, छोटे छोटे बॉक्सेस में ये सारी इंफॉर्मेशन हमने दे रखी है। लोअर लिमिट कभी भी 0.1 से नीचे नहीं जाती है, बिकॉज फर्स्ट ट्राइमेस्टर में, सेकेंड और थर्ड ट्राइमेस्टर में लोअर लिमिट सेम रहती है।
थैंक यू डॉक्टर राजपूत।
थैंक यू पवन, थैंक यू ऑल ऑफ यू।
Dr. Rajput, can I request you to kindly post few of these guidelines of ITS regarding this thyroid interpretation and this group, or if you can send it to Dr.
वो
Pawan?
ऑनलाइन अवेलेबल है पवन, मेरे ख्याल से फ्री ऑफ कॉस्ट अवेलेबल है।
I'll post it in the groups. I'll download it and I'll post it in the group.
और मैं पवन को भेज दूंगा, and Pawan can post in the IMA group.
Yeah.
Thank you, sir. Thank you very much.
Okay, ji. Thank you very much.
Thank
Good
you.
luck.
Thank you.